Hey guys, easy question with some high-yield facts sprinkled in. A 43-year-old woman presents with a 1-week history of rusty-colored discharge from her left nipple, which can be manually induced or occurs without manual expression. We are asked for the most likely explanation for her findings. Pause for a second to make a selection. Choice A, DCIS. This is the wrong answer here. Choice A will be the answer if they tell you there's a cluster of microcalcifications or popcorn calcifications. It usually is in the upper outer quadrant of the breast. But truthfully, it doesn't matter where it is. We're talking microcalcifications, which are not palpable, and therefore, DCIS is not palpable. It is found through mammography, which is why knowing ages for breast cancer screening is so testable. When do you start screening? Age 40 for average risk. High risk includes those with BRCA, a history of radiation exposure to the chest, or a relative diagnosed with breast cancer before 50. Guidelines vary, so just recognize high risk needs a screening before the general population at 40 should be enough. A final high yield point here. For DCIS, they want core needle biopsy, or stereotactic, X-ray, or ultrasound biopsy. Any type of biopsy. Fine needle aspiration is never the right answer. Choice B, invasive ductal carcinoma. This is the wrong answer. Invasive ductal carcinoma is the most common invasive type of malignancy of the breast, where once again you can have microcalcifications, generally found with screening mammography. A tricky question might be, microcalcifications are discovered on mammogram. What is the next best step? The next part of an invasive ductal carcinoma workup is to repeat mammogram. More specifically, the answer would be diagnostic mammogram of both breasts. Then a core needle biopsy. Finally, surgical consult, lumpectomy, with axillary dissection/sentinel node biopsy. If they tell you a biopsy shows stellate morphology, that's buzzy for invasive ductal carcinoma. Choice C, intraductal papilloma. Correct answer? Great. So listen up. I'm going to tell you the sentence you've got to memorize. Unilateral bloody nipple discharge is intraductal papilloma until proven otherwise. That's it. Done. It's literally all you got to know. Okay. So what do we have? Unilateral nipple discharge. You say, oh, that's intraductal papilloma. Not hard. Super easy. Intraductal papillomas are the most common cause of bloody or serosanguineous nipple discharge, especially when the discharge is spontaneous and confined to a single duct. The other options are less likely, as they generally present with different findings, such as a palpable mass or different discharge characteristics.